Thank you, Eric. My PhD is actually not in psychology. It's in neurophysiology with a submajor in pharmacology, which, how many of you planned to be here today when you were 16 or so? No, yeah, right. Life is a very, very interesting process, and so, live it. I never planned to be a physician. At some point, I went to Georgetown, got my bachelor's degree, got interested in brain sciences, actually I hated brain sciences. I was interested in cardiovascular physiology, but the funding in the 70s was in brain research because Nixon was afraid of dying of a stroke, which guess what, he did. So we were very well funded for neurosciences research. So I did neural control of circulation. But then later I got asked many years down the line to help with the Chemical Dependency Training Institute in Miami, at University of Miami. Because we didn't, at that point in the early 80s, mid-80s, there was increasingly a professionalization of addiction counseling. The traditional thing was you had somebody who had good recovery in a 12-step program that got some training in basic psychology and became a counselor. And what we needed to do was professionalize it. So we set up the Chemical Dependency Training Institute. And someone said, why don't you come do that? And I said, you don't need another guilty alcoholic counselor. And he said, no, but we could use somebody who's got a PhD in neurosciences in the field. And so I entered the program, became faculty in that program, and then got asked to help set up the adolescent drug and alcohol program for Dade County through the school system. So we had 300,000 kids in prevention, intervention, and treatment programs annually. It was really a very exciting thing. And then someone said, don't pay any attention to Dr. Derry's not a real doctor. And so I had gone to anger management. I went, we got 2 medical schools in this town, one with and one without a football team. And so at 45, I found myself in medical school. And that, because of prior training, allowed me to be to be board certified also in addition to internal medicine in addiction medicine. And probably the most important work I've done since getting that degree is work with healthcare professionals. I was the chair of the Provider Aid Committee for the largest healthcare system in New Mexico. So we had over 3,000 licensed providers, some of whom had problems, some of people were resolving their problems, some people had a historical problem and needed credentialing verification. And so my work over really the past 12, 13 years has been in making recovery for healthcare professionals an honorable thing. And so I've used my academic background to really kind of stay current on all the trends that are affecting us, both from my background as a counselor, as my interest as a scientist, and in terms of providing practical knowledge for all of us who are clinicians. And so what I'm going to do today is kind of work with you on the endocannabinoid system, which, quite frankly, and you'll see as we go through the course of the talk why, we're only really just beginning to understand, even though weed's been around a long time. But we're just kind of understanding some stuff. So what I wanted to do today is to talk about the myths and the realities. So let's say, what is it? First of all, and you're going to see a kind of a grab bag of different sources of information here. Some of them I pulled off of popular websites, that anyone can access. Some of the data is coming from pharmaceutical companies that I had very, very privileged access to their data. Some of it is peer-reviewed data. It's interesting how it all comes together into an interesting story. First of all, this is from Americans for Safe Access. What is weed? Well, when you go out and get some marijuana, and you can probably find it within walking distance of here. We'll talk about that. It's called ditchweed. Okay, it's native to North America. You know, and you inflame it, okay, and the vapors go up, and you take those vapors to a lab and you analyze it. What's in it? Well, it turns out there are about 483 different chemical constituents in a puff of smoke. If you say, what is a cannabinoid? I say, which cannabinoid? Now, you're probably thinking THC, but there's also which is delta-9 tetrahydrocannabinol, but there's also cannabidiol. And there are 64 other cannabinoids, all of which have more or less and different psychoactive properties. Whoa. So, what's weed? Better living through agriculture, you know? In addition, when you look at it, and you look at that smoke, there are hydrocarbons, simple alcohol, aldehydes, ketones, non-cannabinoid phenols. You know what those are also known as? Biohormones and carcinogens. And so just because something is all natural doesn't mean it's all good. You know, diarrhea is natural, but I don't want it. You know? So weed is kind of interesting, just as something that's going out there, it goes up in a puff of smoke, and it's got stuff in it. And it's not always predictable what's in it, because when you look at the way things grow, there are different strains. And that's going to get us to some of our talk later on. So let's go into the brain and ask first, how do we think about how the brain works? Of course, we're using our brain to do the thinking, and we're thinking about the brain. The classic method of describing this is synaptic transmission. Neuron A up here communicates with the cell surface of neuron B, and A plus B gives you C. So stimulus, reaction, effect. Okay, and every neuron system has only one neurotransmitter. So you have like the cholinergic system, you have the dopaminergic system, you have the noradrenergic system. But so this would be, for instance, for norepinephrine. Norepinephrine is stored in the storage vesicle. This gets activated, the norepinephrine gets released, and it goes across to a receptor, which could be either a second messenger system or an ionic channel system, kind of depending on what the transmitter type was. And it stimulates it, producing either a stimulatory positive experience or an inhibitory experience. So A plus B gives you C, or A plus B gives you minus C. But it's always programmed that way. You know, you go bunk. That's how it works. That's how we've thought of the nervous system all along. And that was in 1997, you know, and nothing's changed in biology, not for about 20 million years. And when you put it together into the brain, and by the way, this is an extremely good article. It's somewhat dated right now. It's 11 years old, Kami et al. In New England Journal of Medicine. But it's one of the best reviews of neurotransmitter systems as they affect addiction. It'll also cure insomnia, because this article is really, really dense. But it is one of the best reviews. So when you look at how the brain works to mediate the effects of chemicals, you see there's a serotonin or 5-HT system, there's an opioid system, there's a GABAergic and a norepinephrine system, and these interconnect from everywhere down in the midbrain all the way to the prefrontal cortex. Here you have the glutamic acid system using glutamine. but you don't see a marijuana system there. You don't see a cannabinoid system. So all along, we've known that marijuana affects the brain, but we weren't sure how it does it. So for instance, if you give someone alcohol, it activates the GABA system. That's the receptor that mediates alcohol. If you give somebody opium or one of the opioids, it activates the opioid system. Duh. And then how it interacts determines what the effect is. And, you know, there's dose-effect relationships and all of that. But we don't see that for marijuana. We know that certain areas of the brain seem to be more or less sensitive as of 2003, you know, but we don't know exactly how this really feeds in for marijuana. Now, obviously, everything summates here in the nucleus accumbens and the ventral tegmental area, which are classically known as what? The reward centers. So when you take a drug, no matter whether it's going through the opioid system or the GABA alcohol system or straight to the dopamine system as the amphetamines, crystal meth, cocaine go to, it all summates in the dopamine system to give you this massive reward. So this lady over here, she looks real polite to me. So I think she enjoys her sherry. Now, this lady over here, I think she's a little wilder, okay? So she may have a different drug of choice, all right? But it all comes together in the reward center. So your tongue may have one set of tastes, but your brain only has one thing going for it, and it's reward. Okay, and if you don't get reward, you get dysphoria. And if you get a lot of reward and then take it away, you get withdrawal. And if you do it too much, then you get tolerance. So all of this is just real simple. It's wiring, it's plumbing, it's chemistry. So we understand how most of the drugs work, but you say, so where is marijuana in that? We know if you put it in the brain, you get an effect. But is it an indirect effect? Is it working through the serotonin system? Is it working through the opioid system? Well, in 2003, we really didn't have a full picture on that. And we began to understand more about what happens underneath the membrane. That you activate these receptors on the surface of the membrane that are receiving neurotransmitters coming down from neuron A down here to neuron B, and it generates other stuff beneath the membrane. Okay? Well, it turned out for marijuana, we were looking in the wrong place. Okay? Because we kept looking at the postsynaptic junction. It turns out the marijuana receptors are on the presynaptic portion of the neuronal system. And you say, well, how does that work? Because you're supposed to have release from here going on to have an effect over here. What happens, and this is the weird thing that we didn't understand, is your body has its own marijuana system. It has an endocannabinoid system. So when neuron A overstimulates neuron B, chemicals called 2-AG and anandamide, which are your body's own endocannabinoids, are on-demand synthesized and spray back across the synapse, stimulating the cannabinoid receptor on the presynaptic, which has an inhibitory effect on neuron A, slowing the whole system down. So that if you go back to look at this, and let's say you're overdriving your GABA system with a bunch of martinis, really revving up your dopamine reward system, you're going, oh man, this is going too fast. Your body has natural mechanisms to homeostatically slow that process back down. Now, let's put this in real time. Okay. This is my classmate from Georgetown in 1965. Okay. He was just another dork down the hall, you know? This dweeb from Arkansas. Here was the dweeb from Alabama. Okay. We were all excited about our classmate Lucy Baines Johnson, whose dad lived at 1600 Pennsylvania Avenue. Hell no, we won't go. This was not one of our classmates. This is a fish that lives at about 3,000 feet under the ocean. Okay? And this fish has more endocannabinoid receptors per ounce in its body than any other animal on Earth. So you have to ask yourself, why? Because marijuana does not grow under the sea. It is not found in seaweed unless a bale fell off a boat, you know, somewhere out in the Gulf Stream, all right? Just doesn't happen. So why has this got more endocannabinoid receptors per square inch than any other animal on Earth? We understand, Bill. I went to the same damn parties. I also didn't inhale. You know, it's peer pressure. You know, it just smells bad. Here. You know? So why do human beings have these endocannabinoid systems? What are they there for? It turns out, you know, I described this whole process that the neuron A overstimulates neuron B, and neuron B synthesizes an anandamide, sprays it back on neuron A, and slows neuron A down, right? Okay, I was trying to figure out what's a good example from our own life that we can, you know, just conceptualize this. And while I was thinking about it, I was driving along and damn near died, because I realized all the lights in front of me, the tail lights were red, and so I hit the brakes, okay? What happens when you put your foot on the brakes and just hold it down? You stop. But do you screech to a stop, or do you kind of slow down? That's because you have an anti-locking brake system, which you're insensitive to. But your car has this little computer that keeps taking the brakes off so that they don't jam, so that your brakes don't lock up. So you smoothly come down to a stop without spinning out of control. So the endocannabinoid system, in its normal physiological function, is your anti-locking brake system so that so no one system overloads the other. And the endocannabinoid system doesn't just exist in one place, it's all throughout your brain on every presynaptic neuron, irrespective of whether it's a dopaminergic, cholinergic, adrenergic system or GABAminergic. So it's on all these little presynaptic areas, and it's scattered all out your brain. And in fact, it's scattered all out your body, but let's talk about what it does for you in terms of normal physiological function. What is it most involved in? Is it involved in getting you a high from smoking weed? No, what we now understand your internal endocannabinoid system does is it regulates your metabolism in large part. It's overactivated in human obesity. There are large amounts of receptors in the hypothalamic feeding centers. If you stimulate it centrally and peripherally, it favors metabolic processes that lead to weight gain, lipogenesis, insulin-resistant dyslipidemia, and metabolic syndrome. Wow. There are two well-defined receptors, the CB1 and the CB2. CB1 are primarily found in the brain. CB2 are found in the rest of the place. There's 2-AG and anandamide, which are the best defined internal cannabinoids that our body makes. And it's interesting, these particular slides I didn't develop. These were provided to me 15 minutes before the website was shut down from one of the major international drug companies that were looking at development of drugs that would work on the endocannabinoid system, and we'll talk about that drug in a second. Here's what happened. Can you all see this well in the back? Okay, we're gonna talk about rats. I hope there are no PETA folks in here. Okay, it's interesting. You can talk about rats and alcoholics because they're not, in their natural state. They're just not real. You can't be too sympathetic about it. No one gets upset about grinding up a rat. Now, if we talked about a bunny or a kitty, it'd be different. Okay, but this is all about rats. All right, so if you look at cumulative food intake, all right, that's 0. That's normal. Okay, but you get creative like I did in the lab, and you put a electrode or a pipette in the rat's brain where you can inject something. The little things are running around, little helmets on with tubes coming out from. Well, sure enough, if you inject pure anandamide, which is one of your body's endocannabinoids, that's the AEA that you saw on the previous slide, look what happens to feeding activity. It goes up tremendously. And if you turn it off, it goes back to normal. So we know that your body's endocannabinoid system really results in major changes in metabolism and basic activities like feeding. What if you could block it? What if there was a chemical that would just block that from having no effect? Well, Sanofi Aventis over in Europe developed one. It was called rimonabant. So if we pre-treat those little cute little rats with the helmets and put rimonabant in their system and then inject the anandamide, look, the feeding activity is no different from normal. It completely blocked the overdrive of exogenously administered anandamide. So there are chemicals that block those receptors. So what if you could use this in humans? Well, they created this drug called rimonabant, and they did clinical trials, proved safety in the initial clinical trials, and looked at its effect on metabolism. Okay, this is placebo, the famous sugar pill, in the blue. But look at body weight, waist circumference, triglyceride levels, and HDL cholesterol. HDL cholesterol is your good cholesterol. Triglycerides are part of that bad cholesterol picture. They gave 2 different level doses, 5 milligrams and 20 milligrams. When you got to the 20 milligram dose, wow, body weight dropped by kilograms. Waist circumference dropped by inches. Triglycerides went way down. And HDL, the good cholesterol, went way up. Did we man, is this a great drug? This is a primary care physician's dream for somebody with insulin metabolic syndrome, somebody with hyperdyslipidemia, hypercholesterolemia. This is a cardiologist. They're just vibrating with joy. Okay. And so after clinical trials were completed in Europe, they established safety and efficacy. They allowed it to go into wide marketing through primary cares in Europe, and the FDA looked at the initial studies and the clinical trials and said, let's open it up in America. Well, by that time, they had had nearly a year of data in Europe, where it was now available for any family practitioner to just write scripts, and people were losing weight and they were feeling good. One of my friends down in Australia, Steve Jurd, who's very famous in the field of addiction medicine, he was doing the clinical trials. He says it was terrific. They were losing weight, they were quitting smoking, they were stopping drinking, and they were getting twitchy. And lo and behold, 2 weeks after this drug was released in the United States, 15 minutes before I downloaded the slide deck that I showed you earlier with the blue backgrounds, the FDA did a black box and said, yank it from the market. Because what was happening is once it went into family practice, general internal medicine, totally out there to the wider community, they were getting larger numbers of people that weren't properly screened for family history of alcoholism or depression. And people, the only good thing that can be said is that when the people hit the ground after jumping off the buildings, they made a smaller impact on the sidewalk because they weighed less and their triglyceride levels were down. High incidence of psychotic, suicidal, depression, adverse events, totally above the normal when it, just went out into mass marketing. What lesson do we learn from that? Is the endocannabinoid system is so widely distributed through the brain that if you unbalance it, if you dysregulate it, you have profound effects on emotion and everything that mediates addiction, mood disorders, and all that can be said is they'll look better in the coffin, all right, because they lost weight and quit smoking. But it also tells us that the endocannabinoid system may be the sticky glue that kind of crosses across all of the systems. And so when we look at cross-dependence from chemicals, you dysregulate one system over here, and you wonder how did this one over here get imbalanced? It's because the endocannabinoid system is represented across the entire nervous system, not just in little bundles of neurons called the serotonergic or the GABAergic systems. So when you look at what happens in the body outside the brain, where largely it's involved in the hypothalamus and the nucleus accumbens, which is the dopamine system for relating to food intake, it has effects on adipose tissue, muscle, liver, GI tract, and the pancreas on everything that relates to metabolism. So that's your endocannabinoid system's function in your body. It's part of you. It's natural. That's the only all natural, all good part about it. It's part of your metabolic regulatory system. So what do we do when we smoke marijuana? We hijack it. You hijack your body's normal homeostatic mechanisms, your normal feedback mechanisms. Now, there are three, when we go out there to the ditch, and start looking at the weeds, probably we're going to find some ruderalis. Okay, it's called ditchweed. People have known about it, smoked it for years. It's like, It's like a, it's like decaf. Yeah. And then the two other major strains that are found in North America, naturally out there, are indica and sativa. And they have two primary, you remember we talked about 66 cannabinoids in a natural puff? The two dominant ones are THC and cannabidiol. And in nature, they're found to be about 1% and 1% in equal distribution. So the total amount in a plant would be, of the major two chemicals, would be 2%, with half of it being THC and half of it being cannabidiol. Interestingly, when Bill and I were in college, that was the THC content of most grass, weed. Look what's happened to it to 2006. It's 1,000 times more powerful. How did that happen? I mean, is this Darwinian pressure or something? No, this is better living through chemistry, better living through agriculture. This is a man-made phenomena of strain selection, crossbreeding, genetic manipulation. The stuff today is not your father's Oldsmobile. So any thinking that you have on marijuana that was formed in your college years, in your training years, and I'm going to my college reunion next week at Georgetown. It'd be interesting to have this talk with at least one of my classmates. Okay. At least one. This is not the same stuff. So whatever preconceptions that you have from the 1970s are no longer valid today. Any statements you hear made about marijuana that you can date to 1974 have no validity. And just to once again show you, here is a holographic 3D model of the anandamide in your brain. Look at its similarity to delta-9 THC. They're essentially similar chemicals. And that's why THC works so powerfully to hijack the brain. It is a substitute version of what your body makes for itself, only in massively different concentrations when you inhale it. And this shows natural stuff that you may grow in your backyard, or find growing in your backyard from the 70s, okay? Which is, again, 1-to-1 cannabidiol to THC. This is some of the newer stuff that has been genetically selected to grow a much, much higher concentration of tetrahydrocannabinol versus cannabidiol. Look at it crystallized on the leaves. It is so rich in the stuff that literally the plant is crystallizing it on its leaves and on its blooms. Okay, this is the stuff that's caused, this will cause a problem. This definitely causes a problem. And this is what's driving the market today. There you can get a better look at it. So when we look at the epidemiology of marijuana, and this is from the SAMHSA National Drug Survey, 2002 through 2011, what we find out that about 34 to 40% of Americans have at some point used marijuana. Okay, but that shouldn't shock us. How many people have taken a sip of sherry? How many people have tested a cigarette? But how many go on to be sometime users, frequent users, or chronic users. Okay, this number I'm not worried about. It's the 10 to 11% of Americans have used in the past year, and the 5 to 7% who are regular users in the past month, and about the 4% who go on to become chronic users 7 days a week, 5 to 7 days a week. Again, looking at marijuana consumption prevalence rates, this is the past 30 days down here, fairly steady over the past 10 years. Past year, but because we're increasing population, more and more people are using. Just because this rate is staying the stable, as the population expands, you have more people out there. This basically says the same thing. So again, if you look at this in pie chart, 42% of Americans have smoked marijuana 12 years or older. That just is, that in itself, you know, when you think of doing studies on people, you think about doing them on adults. That's either, depending on which state, 18 or 21 or older. No, this sampled 12-year-olds. Okay. So if you look at past year, 26%, less than yearly, 57%. These people would fall into the lifetime, ever in your lifetime. But you've got about 8% that are doing it daily or weekends plus. Now, does anyone know the half-life of marijuana, of THC in the system? Huh? Yeah, 14 to 30 days. Yeah, so do you have to use it on a daily basis? No, if you're using that crap with the crystals on it, you can probably do it once a week. So it's this crowd that are the real concern here.
Ask your question. Mm-hmm. For the areas that are legalizing marijuana, where will they fall on regulating the potency? Will it be that crystallized leaf, and will there still be a market for that potency?
Hold that thought. Hold that thought. Very, very good question, and we're going to talk about that a little bit later. So normal, now I just gave you the SAMHSA data. Okay, now
About that SAMHSA data, I treated kids back in the 90s that were doing it 5 and 6 times a day.
Oh yeah.
That just says how many days a week.
Correct. Yeah, it doesn't reflect how many times a day during that time per week. Yeah. So again, that's just kind of an epidemiological thing, not a clinical driver. But it gives you something of the magnitude on it. And whether you're doing it once a day or 6 times a day will come to a question that we're going to ask later. Okay. So, you know, for those of you that, you know, are conspiracy theorists, we know our government has agendas and all that. So let's flip to the left side of the picture here and go to the National Organization for the Reform of Marijuana Laws. What did their statistics say? Because these are the folks that really want you out there being able to drive into the Wawa and come out with the woo-woo, okay? All right. So NORML also reports that about 8% of marijuana users develop a pattern of abuse and dependence problems, which actually correlates very interestingly with the SAMHSA data, you know, the mean government guys, you know? And about 8 to 9% meet diagnostic criteria for cannabis dependence. And this is Alan Marlett, who is very, who's very into the field of harm reduction. You know, whatever, harm reduction to me is like, okay, we just don't want you to die as painfully. Anyway, but it's very interesting that you have two groups, the federal government and NORML, who have completely competitive agendas coming up with the same numbers. Okay, so is marijuana really addictive? Let's take a break and come back to that. All right? All right, that's what So back to the question. Dr. Adair, is marijuana really addictive? Well, first I want to return to something we talked about earlier when we looked at both the SAMHSA data and the normal data, or the normal, NORML. Okay, first of all, what do you recall about that? How many people over time on an annual basis probably meet criteria for dependence? About 8%, 9%, maybe 10%, depending on who you look at on that. How many people, so is that like a big number? Correct. Thank you very much. It's the same amount as alcohol. Alcohol actually is probably 10 to 15%, but we've been following that number with better criteria for dependence for a much longer period of time. So really the magnitude of the problem is potentially the same as the magnitude of the problem for alcohol. So if we're going to have a beautiful campus like this for the treatment of alcohol as well as some other drugs, and if you look at the prevalence in treatment centers, and I'm program director at one, I'm here at what I call a sister facility. We're on different ends of the country, so we're not really competitive. But Farley and Hazleton are two of the most distinguished programs in the country, you know, in terms of integrity, ethical levels of care, meeting evidence-based standards of care. And so even though the ones that get the big news today are the methamphetamine users, you know, crack whores are just really kind of déclassé these days. It's the methamphetamine users and the heroin shooter-uppers, you know. But they're actually a very small percentage of the population. When I look at all in our healthcare professionals, you know, yeah, they're the benzo users, they're the opiate users, but in every case, alcohol is always in the picture. Okay, so we can't forget alcohol as the mother drug. And that if we're looking at epidemiology, which shows us a use pattern of percentage of users that equals alcohol, then we have a similar problem. So the question is, are we dealing with real addiction here or use disorder? Okay. Now, for instance, in alcohol, yeah, maybe 10 to 15% of the population get addicted, but can anyone get drunk and cause an accident? Yes. Correct. And so that needs to always be remembered. A person may not become addicted to a substance, but while using it is certainly impaired and can cause harm to themselves or others. So casual use can still be deadly use. So let's look at the component of addictions. These are classic. So if we're going to ask the question, is marijuana addictive? I don't care whether you're in DSM-4, DSM-5, there's certain basic principles. There's use, abuse, tolerance, continued use despite consequence, and presence of a defined set of symptoms upon cessation. Now this has been problematic with marijuana because when you got a half-life of 28 days, who's going to sit around and watch? It's like watching grass grow. Did I say that? It's like watching grass grow. But the other thing is, if your preconception is 1974, when it was 1%, versus 2006, when it was 10% THC, yeah, you're going to have a slightly different effect on the body. So, this is a very, very good piece of literature that was published in 2011, where they looked at cannabis withdrawal scales, several of them, and looked at their validity and looked at what their common points were. And they looked for patterns and predictors of cannabis withdrawal and distress. Okay, so I'm now moving this from the realm of hearsay to peer-reviewed evidence-based medicine. And so what the background was that they looked at 160 million users worldwide, 2.1 million users annually, 10% of users becoming dependent, with an odds of dependence of 1 to 2 with daily use. Okay, and that was, to me, the real contribution of this study. They really went and reviewed all the data worldwide. And lo and behold, this looks like SAMHSA data, this looks like normals data, with a few squiggles in the percentage points. But the interesting thing is with daily users, the odds of dependence are 1 in 2. So you got a 50% chance of meeting criteria for dependence if you daily use. So their inclusion participants, they had 49 people that completed their entire study. Their usage was 5 or more days per week in the past 3 months. They met DSM-4 criteria for cannabis dependence. They had a previous experience of 1 withdrawal symptom, and they had a willingness to quit for 2 weeks. So their baseline thing is they did a baseline assessment, and these people would check off on a paper, what is your withdrawal symptom, and you grade it 1 to 10. They would have 1 week of daily monitored smoking prior to cessation, have a quit session, and over the next 2 weeks, they would do a cannabis withdrawal syndrome questionnaire daily of 26 different items that they rated. And they had been educated on this prior to this, so they had a daily symptomatology so they could screen out just kind of background aches and pains from withdrawal symptoms. And they coupled this with urine sampling. And they weren't looking for glucose, all right? So here we have the cannabis usage as reported and the urine tetrahydrocannabinol concentration. And now, I said I didn't use, but what's the urine saying? Okay, so what you see here at baseline, everything correlates. Smoking as usual, and then the urine concentration going down, abstinence week 1, abstinence week 2. So you see in the cannabis use, at week 1, it's 0, but there's still it's coming down. All right, so these people really were becoming biochemically abstinent, and at the same time doing the 26-item rating scale. So look at their total cannabis withdrawal scale. And the flat lines here are average smoking their scores prior to stopping smoking. And these are what happened with their withdrawal severity. And these are the mild symptoms, these are the severe symptoms. Wow, what a clearly demonstrable pattern over a 2-week period, certainly peaking at 5 days, but not coming down to below baseline until 10 to 15 days into the system. So if you admit somebody into treatment, when are they going to be ready to receive treatment? Halfway through their 28-day treatment, because they're going to be profoundly distracted by withdrawal symptoms. And when you looked at all the items they rated, look at, and this is the highest validity, was sleep disturbance, followed by angry outbursts, feeling irritated, physical tension, nausea, restlessness, nervousness, cravings, depression, loss of appetite, headaches, and stomachache. Now, you're a clinician, you may be a physician, you may be a nurse, you may be a tech working with the patients. And you're sort of vital sign oriented. What is going to be most concerning to you? Probably stomachache, headache, or nausea. What's more important to the patient? Sleep disturbance, angry outbursts, and feeling irritated. So one of the things, and I wish Eric Martin, who is the director of the Oregon Accreditation Board for Counselor Certification, he is really a phenomenal expert in the field of marijuana treatment. And I would highly recommend bringing him out here to do something on treating the marijuana addict. Because Eric has been doing this for decades. He is brilliant. And he will tell you that you cannot come into the room with your expertise and invite the addict to come over here to be treated. You have to go over to where the addict is and treat them where they are. So if you're worried about their headache and stomach ache and they're worried about their sleep, you're already not on the same page. And so this is a very, very important thing. And if you think they're going to make sense to you on day 5, they may appear to make sense, but they're still up at this level. You know, they're distracted. And you saw it in that. Don't even start treatment until they've been out on the ranch for about 2 weeks. And this is what I see with healthcare professionals that I have in treatment that have had, you know, again, they always come in for some other problem, but then you do the history and physical and find out they've been smoking pot or doing something like that. Automatically, that buys them 45 days in treatment because they don't start making sense for about a month. They don't retain cognitively what we're seeing. So yes, there is a withdrawal symptom and it helps drive addiction. So are there valid medical uses? You know, that's the big deal these days, medical marijuana. That's where all the hype is. So is there any reality in all this smoky myth stuff? Well, I've given you some you know that the endocannabinoid system is natural in you. Marijuana is not natural in you, no more so than it is in that fish. But the endocannabinoid system is part of your regulatory system in your brain, homeostatic regulatory system. So are there, somewhere in this whole mystery thing, is there true valid medical use? So let's look at some stuff on that. Here is an endocannabinoid drug. It's called Marinol. It's been around for a long time. It was the first and only drug that the FDA has ever permitted. And it is THC and sesame oil. Okay, and it's only THC. It's not THC plus cannabidiol. It's not THC and one of the other 64 chemicals called cannabinoids that are found in pot. It goes back to 1985. It's synthesized in the laboratory, so it's constant, it's quality controlled. We know the dosing, we know what's in it. It's sesame seed oil. It has very poor bioavailability. Only about 20% of it maximally of an oral dose actually reaches the brain through the systemic circulation because it's so rapidly metabolized in the liver. The onset of action is slow. The peak plasma concentrations are not attained until 2 to 4 hours after dosing, whereas inhaled marijuana is systemically activated within usually 30 seconds of an inhalation. It is effective in naive users, okay, but it has common adverse effects such as anxiety, confusion, depersonalization, dizziness, euphoria, dysphoria, somnolence, and thinking abnormalities, which is the effect of pure THC in your brain. Okay? Well, they were dealing with terminal cancer patients, and that will come into discussion about the medical marijuana laws, okay? So they were dealing with naive users. Now, there was a very interesting study that I've never seen published, but I did hear presented at ASAM in 2004. The reason I know that is Carrie Edwards were running. And yeah, there's some associations there that are just phenomenal. Anyway, this researcher presented at ASAM a great study. What he did is he advertised in the Village Voice, got funding for this, advertised in the Village Voice for chronic potheads to come in and smoke all the pot they could. Okay? And here's how the study was designed. They had buckets of pot, just bales of it. And they had TVs, and they had magazines, they had couches, they had all this. Trick was you had to be hooked up to an IV, okay? And that IV was hooked up to a machine, and the IV ran all day while you were in there smoking pot. And what they did is they had mirrors, which they could film these people and watch them and have, graduate students who were going, lucky guys, checking off behavioral observations. And one thing, the guys would come in, it was all guys, hey, puffing up, doing the thing, and then they'd put some Marinol in the IV, THC going in, and they'd watch them stop smoking, for a bit, because all they thought was saline, running. And then they'd turn off the THC, and just a little bit later, the guys would start puffing up again. Turn on some THC, they'd quit smoking again. They're reading their mag, turn it. So they were able to figure out that the dose of Marinol that affects a chronic user is 60 milligrams. What does Marinol come in? Max, 5 to 10 milligrams. Yeah. So for chronic users, this stuff doesn't touch it. Now, if you're a naive user, which most cancer patients are, yeah, Marinol will work for you in your last 6 weeks of life. Interesting. If you, as a prescriber, start prescribing 60 milligram doses of Marinol, you will have the DEA visiting your office, questioning you. Because when you start doing 60 milligrams, all you're getting in a lot of people is anxiety, confusion, depersonalization. Yeah. So Marinol is a very valid drug and with very limited use. There are scientific trials. This was in the 2 weeks that Ramanabhat made it in this country. It was called Acomplia. And so we know that it is very valid for metabolic syndrome. We know that it reduces alcohol consumption and nicotine consumption, but we also know they get twitchy. There's evidence that the cannabinoid gene receptor, modulation of that, reduces cocaine dependence and IV drug use. Okay, so if you have a modification in your endocannabinoid system, you may have a different sensitivity to cocaine. And the modulation of the endocannabinoid systems modulates the GABA, glutamine, and the dopamine systems, which are the systems that modulate alcohol. Okay? So that's why I talked about earlier that the endocannabinoid system may be that sticky glue across your brain that holds the whole thing together in terms of being able to affect cross-dependence, because you have the direct THC effect, you have effects on cocaine, you have effects on nicotine, and you have effects on alcohol, all caused by modulation of the endocannabinoid system. If you knock out the cannabinoids receptors in the brain, it blocks the social withdrawal in schizophrenic activity in mice that are given PCP. One possible area for future research is stimulation of the CB2 receptors, which are the ones that are outside the brain, that are in the liver, actually has been shown to regress fibrosis seen in cirrhosis, either caused by hep C or alcohol or hepatitis B. So there may be some therapeutic use for CB2 stimulants, none of which do we know yet.
Research being done on the CB1 to where it could be worked in a way to help reduce just general schizophrenia?
Well, again, the research is too early on in the game on that. There's a lot of anecdotal stuff, and we'll talk about where that's coming from when I show you the slides on the New Mexico program. Okay. There's some correlation in the CB2 gene polymorphism that predicts severity and existence of alcoholism in Japanese subjects. So again, there's some really interesting breakdowns, and this is only just being understood now, because if you remember looking back at those slides that I was able to download from Santa Fe 15 minutes before the website went dark, the dates on those slides are 2005, 2003. This is areas that we're only really beginning to understand that this system exists and that it has subtypes, and it's new science. It's new frontiers. CB2 receptors and pain. Okay. It turns out that certain agonists, and this is an experimental CB2 agonist that's in development, inhibit nociception, which is pain. It's a $25 word for pain, without producing CNS effects. So it doesn't cross over to the opioid system, okay, or the enkephalin system. And the CB2, when you start looking at where are CB2 receptors found and what are they active, it's associated with, it modulates acute pain, pain associated with nerve injury like neuropathic pain, chronic inflammatory pain, whatever that is. That can be arthritis, that can be fibromyalgia, that can be a whole bunch. It's kind of a grab bag term. Post-surgical pain and cancer pain. Cancer pain is deeply visceral, usually due to an activation of both axonal tracts, ganglia, and so CB2 receptors, because they exist very widely across the body in all systems, modulation of those can affect all of those. But again, there's only one CB2 agonist in development that I'm aware of. And I'm not sure which drug company and where they are in their trials on it. This is a very interesting drug. This is called Sativex. It is available in Canada, and it is FDA is looking at making it available here. And it is a synthetic 1-to-1 ratio of, it is actually an extract, it's not a synthetic. It is a true cannabis extract from cannabis plants. But going back to the question of how do you know what's in this crap, you know, it is actually analyzed so that they know that it is an exact 1-to-1 ratio of THC and cannabidiol. And the interesting thing about THC is THC has this wild stimulatory effect in the central nervous system, producing actually in high enough doses psychotic breaks. Cannabidiol, its sister cannabinoid, in a 1-to-1 ratio antagonizes those psychotic effects, those soaring central effects, without changing the peripheral stuff. So what they have done is created a nasal spray, an oral mucosal spray. You spray it and go like breath mint. Okay, single dose spray onto your oral mucosa. which is, like Suboxone is where Suboxone is absorbed. It is absorbed in the mucosa, goes into the system, and it's extremely effective in MS neuropathic pain and for cancer pain. The onset of action is 15 to 40 minutes with that administration, and it allows patients to titrate their doses. So there are U.S. trials that began in 2007, and we're hoping that based on what's going on in Europe and what's going on in Canada, that this will be available for certain types of pain relief. Now, because it has that 1-to-1 ratio, you don't get the central effects of intoxication. You get the pain effects. But it'll still show up in a urine drug screen as positive for marijuana. Okay, so this creates, some issues about if you're a safety-sensitive person with a qualified chronic pain issue, can you take this and still work in a work setting that is a drug-free workplace? These details are massive to work out. But yes, this looks like to be the second approved cannabinoid agonist drug that will come into the market here. And it does not appear to have abuse potential. I mean, the reality of it is, for any of us that treat Ultram addicts, believe me, every drug that comes onto the market, believe me, we need to look down the road, may have abuse potential, even though it says not on the front end. Okay, one of the bigger things is again, and I like the juxtaposition of SAMHSA and normal. You have the free press and the paid press. All right. Is there valid use for medical marijuana in certain really chronic conditions? Well, this just came out 2 weeks ago in Neurology. It's a peer-reviewed retrospective of all literature on this. And I was just ecstatic when I saw it, because I have had my suppositions for years. But, the little piece of data over here, a little piece of data over there. These folks are to be greatly complimented for reviewing all this stuff. They looked at only solid clinical trials using known compounds of known content, of known strength. So what they did, they looked at oral administered agents, oral mucosal sprays, and smoked. They looked at who the providers were: Canador, Marinol, Sesamet. These are the providers. IKF in Berlin, NIH in Bethesda, Solway Pharmaceuticals in Marietta, Meta Pharmaceuticals in Somerset, GW Pharmaceuticals in London. So we know the sources on all of this. We know the quality controls that were in there, except, of course, in smoked marijuana and cannabis, one of the cannabis extracts. But they knew the components of THC to cannabidiol, or presence or absence of, and here's Sativex down there. That's classically called a nabiximol. They looked at the smoked marijuana and found out that it was 4% THC, and they even standardized the dosing, 4 puffs per day. Okay? So they really had very good quality, because I don't know, what's in a puff? How many times a day were you smoking? What was your source? We finally have a bunch of studies where they actually knew what was going into the system. And they looked at these disease states: multiple sclerosis, Huntington's disease, levodopa-induced Parkinson dyskinesia, Tourette syndrome, cervical dystonia, and seizures, all of which have been putatively said to benefit from medical marijuana. And they said, based on known administration, what was objectively affected. Now, I will tell you this. When you read through all of these studies that were cited, subjectively, the majority of the patients said they were improved. Hey, yeah, if I feel good, I feel good. Okay, but were they really improved? Just because I say I feel better doesn't mean I'm not going to die tomorrow, you know? Well, so they looked at objective clinical markers for everything to say whether this was effective. And they only found in MS spasticity that there was effectiveness in oral dosing, a possible effect of smoked marijuana at 1 year, but ineffective at 15 weeks. So you had to toke up for a year before you possibly had an effect from the smoke. Oral was effective, okay? Nabiximol, that's the Sativex. This would be the extract, oral extract. That was effective, that was effective. There was a probable effectiveness in centrally mediated pain and painful spasms. In bladder dysfunction, probable with the Sativex, ineffective for all the others. And for tremors, possibly ineffective, probably ineffective, probably ineffective. For all the other disease states, despite all the research that was done, there was either no reliable conclusion or insufficient data. And so after all the hype that you see about medical marijuana, despite everybody says they feel better, and if you feel good, God bless you. But don't tell me it's working. Okay, there's a difference between it's working and I feel good. Some of this stuff is not working. The goods aren't there. There is no delivery of goods. And interestingly, when they looked at the number of patients that discontinued because of adverse effect, there were 1,600 patients that were treated for equal to or less than 6 months, and nearly 7% stopped due to adverse effects of nausea, increased weakness, mood changes, suicidal or hallucinatory ideation, dizziness or syncopal-like symptoms, fatigue, or feelings of intoxication. And when they looked at the ones treated for more than 1 year, which was 207 patients, in addition to all these symptoms, what's not promoted by normal is that THC interferes with your cytochrome P450 system, which is very important in drug metabolism, making opiate therapy less effective. So marijuana actually interferes with other medications used for pain management. So, where can you use it? Why can you use it? Where are you going to get in trouble? Largely, this kind of resembles the electoral map of the United States. Here are your red states, there are your green states. And the reality of it is in a lot of states, it's just bad. It's criminal. You're evil. You're bad, regardless of what the scientific data says. But in others, it's still not consistent. So if you live in New Mexico, you can get medical. You can go up to Colorado and do damn near anything. But if you go over to Utah, you're going to get arrested. You had your hand up.
Yeah, I was thinking about the fact that it shows that it reduces the opioid effectiveness. Would it also be useful for could you use it as a way of reducing opioid addiction, which is a harder...
No, because if you reduce opioid effectiveness, then somebody's going to use more and more with less and less effect, actually driving opiate addiction. Because they're going to have to take more opiates to compensate for the... Well, that's like using one poison to fix another poison. Yeah, it's just not a pretty picture there. Yeah, because we're clear about the data with opioids, and another topic for future, is the whole opioid hyperalgesia, syndrome. That's worth an hour or two in itself. So, no, don't go there. So, the states are making this more and more complicated. And why are they doing it? Let me talk about because I practiced in New Mexico for 11 years while this was all going on. So there's just a little bit of short history here. Why did we establish this in 2007? Because of two patients, Lynn and Aaron. One who had intractable, incurable, progressive multiple sclerosis, and the other had bad cancer. Okay? And 3 legislators, one of whom was a family practice doc, and 2 others who were not physicians, just slammed it through the legislature with all their friends. I happened to be on the governor's pain council for the state of New Mexico, and our pain council was never consulted on this legislation. It just, look at these poor people, let's do something for them. And all the legislatures jumped on the bandwagon and probably got a new road in their district, as an add-on. So that's how it was a compassionate act by the legislature. It was not evidence-based, it was not medically reviewed, and proper consultative agencies were not consulted. So we got it. And the original conditions were all the really bad stuff. But then they added other stuff, like painful neuropathy. Okay, and PTSD. Now, what's really important in New Mexico is New Mexico exists because of the federal government. New Mexico is a third world country that has U.S. interstates, American phone service, and is hooked up to the grid, okay? It is a third world country. It has military bases. It's where the first atom bomb came off. We have testing ranges. We have lots of retired military from the Vietnam era. Lots. So look what happened when they added chronic pain and PTSD. Bingo. And as part of the package, they're putting in a gross receipts tax. Right. It's the gross receipts tax on marijuana is higher than the gas tax. And it's addictive to legislators. What happened in Colorado on the price of an ounce? It went up from $100 to $400 an ounce. Yeah. Now it's come back down because supply began to meet demand. None of this is now being medically evidence-based driven. It's all state revenues, and it's all voter satisfaction. Because when you got a voter base of a bunch of retired military who will show up to vote on election day, the legislators knew what they were doing. Okay? The genie is out of the bottle, folks.
I heard it's the fastest growing state in the nation right now. People are moving in from all over the country.
Yeah, and so you're seeing population shifts, how this will affect elections, who knows. But the reality is when you look at the purity, the variability in medical marijuana versus it's taking you back to the dark ages where you would go into your pharmacy and if you had a cardiac dysrhythmia and you needed quinine or you were going to an anti-malarial, an area of the tropics where malaria was endemic, they would give you a bag of chicona bark and ask you to chew it. Would you accept that today if you were taking a trip to the Panama Canal? No, it'd say, give me the damn quinine tablets. But no, we are basically telling our veterans, we're telling our medical patients, go out and buy a bag of shitweed, which is another name for ditchweed. Seriously, that's what the potheads call it. The one that grows out in the ditches that has about 1% THC and isn't particularly effective. Okay, this is bad medicine, but that's what we're doing with it. The considerations that were not given in the original compassionate use strategy is that people with chronic debilitating diseases like PTSD, like chronic pain syndromes, what is going to be the effect of daily marijuana use over time? Well, interestingly, in 2012, there was a peer-reviewed study on the effects on the pulmonary system of smoking marijuana. And the joke of it is, it's better for you than smoking cigarettes. Because when you smoke cigarettes, you go, and all the junk settles down here and you don't breathe deeply. When you smoke marijuana, you have to go, hold it in, hold it in, hold it in. And that inflates the lower sections of your alveoli, which most people don't do except when they're exercising. And so it actually improves pulmonary reserve. Okay, now what the long-term effect of all those other terpenes and aldehydes and all that on your bronchial tree isn't fully understood yet. So don't go out and start prescribing this for your COPD patients. Okay, can kids use this? Well, in 2009, in the Journal of Cancer, there is a higher incidence of testicular germ cell tumors in adolescent males who are chronically using. Now, this may be a solution to the problem right here, because they will not reproduce. Because the cure for those tumors is, all right, but no. So would you want an adolescent, here, have some pot, it'll make you feel better until you have cancer. Okay, and cancer in an area that's very important to adolescents. Okay. The data is not clear on driving and other safety-sensitive functions. And I'm going to give you an example of this. I had a physician in treatment recently who has been using marijuana since the age of 14 and was a daily user since the age of 17. And actually made it through medical school residency and their first entry into practice before it became a problem for them. It was never picked up along the way. And so was that person impaired? Well, they made it through med school. They became board certified. Yeah. I think the question goes, if somebody starts out with an IQ of 140 and they smoke marijuana every day and it drops their IQ down to 105, when you finally figure it out, they're still 5 points above the average population. And we don't know what we've lost because we never knew what was there to begin with. Okay, so that's an issue there. This appears to be the same thing in driving. Chronic users certainly show some impairment of complex functions of information processing, but not necessarily in terms of standard reflexes. The ones that are concerning are the intermittent users and the naive users, because these are pretty profoundly affected. You know, what they do for bus drivers to test their readiness, they take them and sit them in a chair with a brake pedal in front of them, and they flash a red light, and they're supposed to hit the brake pedal every time the red light flashes, and they check reaction time. This is impaired immediately in naive users and in intermittent users. And guess how long it's impaired for on single dose administration? 7 days. Yes. Yeah, and those studies have been around for 20, 25 years out of Department of Transportation's studies and are corroborated in these. So again, it's like drunk driving on New Year's. It's the amateurs that are the problem. The real serious drunks stay home. Okay. So so this is a real question. And this has affected us in looking at what we can do with physicians who come, because we have an aging physician population in this country, aging healthcare providers. So doctors and nurses are staying on in their careers for many more years than we should. I mean, whatever. Because of lack of supply of doctors and nurses, and also with the recession, people are choosing to work longer. And so they're coming up with more chronic conditions that are requiring opiates. Some of them may choose to go in medical marijuana states and say, I'm taking medical marijuana because it's all natural, just like diarrhea. Okay, and so can these people be allowed to practice in their careers? They can be allowed to practice in their careers as human beings as long as they're in one of those green states where it's legal. But there is no medical staff affairs, no risk management person, no medical board or monitoring board that is going to allow a professional to practice while using medical marijuana, because there is no data to say that it is safe. Because in that case, we got to protect the public, not the patient. All right, so they can go do it, and I have doctors. Remember, I'm in one of those states next to the state where it's legal, the state of Washington. So I've had doctors come in for treatment and say, I can do it. It was legal in Washington. Correct. It's legal for you to be a citizen of the state of Washington, but it's not legal for you to be a practitioner of medicine and do that in the state of Washington. And that's the ethical and professional and counseling and therapeutic dilemmas that we're into. And then once again, there are lack of standards for interpretations of level and what is driving under the influence of drugs. And this, again, thank you, Normal. They made the graph for us. It's all over the map. And again, it looks like the electoral map from 2012. Here are your red states, only they're in gray, and here are your green states, formerly blue. But so, yeah, you can, for instance, in these states like Ohio and Pennsylvania, you can drive while smoking unless you get a blood level above 2 to 5 nanograms. Okay? Who knows what their level is when they're in bliss and driving? Okay, in Iowa or Wisconsin, any THC in the blood is a conviction. In Arizona, Illinois, and Utah, marijuana metabolites. So again, any marijuana in the blood. So let's say you have a prescription for Sativex or Marinol, okay, for a legitimate medical need. Yeah, you can take them if you've got the correct prescription for them, but you can't drive in those states. So once again, the poor guy in New Mexico gets on a plane to go to Colorado and then goes to see his sister in Utah. Man, that is not going to be a pretty picture. Okay. So what do I really think? I think our medical marijuana programs do gross disservice to our patients by providing a mix of unregulated drugs of unknown content and toxins without standards. The politics distract from potentially valid medical uses, especially the ones on the CB2, and the potentially valid uses are trumped by the known addictive properties of CB1 activation, which is those cannabinoid receptors in the brain. If I wanted a medical second opinion, I would go to the Mayo Clinic. In my neighborhood, it's called Scottsdale. This is your options in California and in Albuquerque. Really high-class joints, all right? So, what about the illegal ones? They're a mess. You know, you can make it in your microwave, and these are just some of the compounds that can be synthesized to do the synthetic cannabinoids. And these are the ones that show up as K2, spice, and all this. What is in this crap? Who knows? You know, but it does activate the system and cause major, major problems. And I have treated people for spice with acute effects of this and withdrawal in the hospital. Intractable nausea and vomiting that went on for days, causing GI bleeds. And it turned out it was a dialysis technician who was taking spice because they knew it wouldn't show up on a drug screen, but if they smoked marijuana, it would. It was a medical professional that I was treating. Other stuffs, yeah, whoopee. So if nothing else, after this fun morning we spent together, you understand the munchies. So I want to thank you. Do you have questions? Do you have comments? Yes.
Address the issue of legalizing for recreational use and the potency. What would that?
Again, there is no standardization for potency. Yeah, and so when you walk into these shops, it's whatever they tell you it is. But what you can be sure of is it's going to be probably in the range of that. Yeah. They'll hype this, but they'll sell you that. And again, the potency differential is this. Yeah. Johnny.
Thanks, Randy. So 2 questions. One is related to Nabalone, which I understand it is FDA approved.
Right.
The only synthetic cannabinoid. I've never seen anybody prescribe it, and the cost is a lot more than Neuronal.
Correct. Yeah, and again, it's used in very extreme cases. It doesn't give you a good high, and when you push it in doses that really a chronic user would want, the adverse effect profile goes up very, very high.
And then the other question is, spoke to an addiction psychiatrist at a national meeting. Won't say who it is because I don't agree with it. Is he actually does use Marinol for patients with cannabis dependence as a way to, quote, maintain them, I suppose, for cravings or whatnot. And I don't know about that, but it's fine.
I would, Marinol for cravings is, I think, like using benzos for alcohol craving. It's not dealing with the issue. It may be doing harm reduction, but it's really getting the patient no place. You know, I think there are better approaches to work for people that have persistent cravings. And we don't have any data on naltrexone and cravings related to marijuana. But the cravings that relate to marijuana, I think, are more due to a chronic dysregulation of the opioid system via the dopamine system. And it would be interesting to do a trial of naltrexone with that. But I just think it's bad science. Yeah, and again, the patient may feel better. And if that's the goal, and the patient is saying, I'm not having to go into the weed shop or obtain illegally because I'm using a legally prescribed dose, go for it. But I still don't want you driving a school bus. Yeah. Yes, ma'am.
You mentioned that the natural versus the man-made, the potency is higher. So does that mean that the half-life is going to be longer for the more potent marijuana?
Half-life is half-life. It's all the same, but it's going to start out at a higher level, so the level of intoxication and effects are greater. And therefore, that will predict that the drop in the withdrawal is going to be more severe. So if you go back to that slide where we show what are the patient-reported symptoms, they're going to be all over the place with sleep disturbances, irritability, and anger. Just the type of person I like to be in a room alone with. Yeah. Yeah, the slope of the withdrawal is going to be greater, but not the length. Yes, sir.
Do you have any free samples?
You wouldn't want it because I go back to that 70s stuff. But I will tell you something else that I learned when I was in Australia recently. Australians have a really dynamic research program in this. And one of the universities there actually has a contract with the government to analyze everything that gets seized. And one of the studies they did recently is they took diagnosed marijuana addicts who they knew were clean for a period of 6 months. You know, they really had objective evidence that these people hadn't used. They had urine drug screens, they had behavioral stuff, they had, observational data. They knew that these people had not used for 6 months, but they had been very heavy chronic users in the past. And what they did is they put them on treadmills and exercised them for a period of time, getting them up to an area of anaerobic metabolism, breaking down fat. Guess what showed up in their urine? Pot. Yes, cannabinoids. Because excess cannabis is very highly lipophilic, and it goes into your fat reserves. And so these people, and they got some, the patients themselves reported that during exercise, they got a high. And it wasn't that runner's high. Okay, and yes, cannabinoid is out there. So this is something that's, it's a counseling point, that just because you quit using doesn't mean it ain't in you. And you can have some kind of recurrent episodes. And people have talked about flashbacks, with marijuana. And I'm thinking that what it was is they started metabolizing some of last year's weed, from that Christmas party. But the other thing is, it's important to know if you're an MRO, that if somebody shows up with pot in their urine and they swear they haven't had any for whatever period of time, to at least ask the question about their level of exercise prior. Yes, ma'am.
We've noticed that, I work here, and we've noticed that when we have folks who've been using a lot, they don't exercise, don't do anything. We have a lot of footprints, and they exercise, they can go to run, all of a sudden they have pot.
All of a sudden they got pot in the urine.
And they're like, what the hell are you talking about? I haven't used anything, I've been here. And so that all makes sense now because they start exercising, and they're doing several times a week.
Yes,
What's
exactly.
the level normal when they do test positive? So what's the creatine level normal when they do test?
Oh, it's normal creatinine.
I mean, like, what's the ratio?
Oh, I don't know. I honestly don't know that.
Yeah.
Yes.
This is another topic in another lecture, but where are the receptors for people with behavioral addictions?
Behavioral addictions are fascinating. I still think it all comes back to central regulation of the reward center. Everything feeds into dopamine. It's all about dopamine. Yeah, there are no receptors, but if you do something, it's like a kid's toy. If you do something over here, a little engine goes over there, tripping off a bulldozer over here, which does something to something. Dunk, 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 dopamine. Dopamine outlet, yeah. Well, I had that too. When I did my training, I did my original supervised counseling training at Bethesda Manor, which was the little crack house by the sea in Miami. It was run by the Diocese of Miami, and it was an old house, that was about to fall down by the bay, and, it was about on any day you had 30 addicts and whatever. And what did we have across the street? We had a crack house. Yeah. Yeah. Mother Teresa came and visited me there one day. I'm not kidding. She showed up on the doorstep. Right. Well, listen, I thank you for your attention. All right. Thank you all.